Hello everyone, it's me again. I guess this is going to be the one and only session you'll be hearing from me for the cardiovascular blog. But there's good reason for me to be specially delivering this session to you. And that reason will be something that you'll find out later on at the end of the session. Now, what we are going to learn today is on the cardiovascular adaptations to exercise training. What this means is that you will be learning about the adaptive changes of the cardiovascular system in response to bout of endurance exercise training. So after long-term endurance training, what happens to the cardiovascular system? And there's good reason for you as future physicians to learn all this, and I'll explain why to you along the way. Now, as you know, I run a human performance and applied physiology lab. And what this means is that I actually run an exercise lab where I recruit human volunteers to the lab. We put them through strenuous exercise training. And then we study the physiological changes in response to the strenuous exercise that we put them through. The idea is to devise various strategies to see how we can enhance human performance in response to exercising in various environmental conditions. But as you expect, we will have to make sure that all the recruited participants are healthy, not just physically fit, but also clinically fit to be enrolled in our study. So what this means is that we will have to send our participants out to third-party physicians to make sure that they undergo a series of clinical testing before they can be certified fit for our study. So this is one example of the medical report that was sent to us after the participant has been certified fit. So this guy here was one very fit volunteer that we had about more than a decade ago actually. So he went into the clinic one day and informed the clinic that I need to go through all this battery of tests. And one of which is of course the ECG, resting ECG. So the nurse put on the leads and then the ECG will be churned out. And in this day and time, the machines are pretty sophisticated. They can automatically interpret the ECG recording. And this was what was given by the machine on that day for this particular participant. ECG machine interpreted that, wow, this guy has marked sinus bradycardia. There's signs of left ventricular hypertrophy. Signs of first degree AV block. And what's more scary is that this guy has V2, V3 ST elevation, and the machine says that, wow, this guy has acute myocardial infarction coming, okay? Essentially heart attack. So, of course, the nurse will start panicking. And when the nurse delivers to the attending physician, he will have to make a decision on whether this guy can actually be enrolled in strenuous exercise study like mine. So my first question to you is that if you were the attending physician that day, would you allow this individual to participate in the strenuous exercise trial that he wants to participate in? Yes or no? Simple, yes or no, right? Some of you may say, hey, you live life only once, right? So YOLO, yes, go ahead. Some of you who are more cautious would say no. So let's see. Now, most of you, I'm sure, will be leaning towards the cautious end. I wouldn't want to certify this guy fit and then he starts to collapse in somebody's lab and the blame is all on me. But the attending physician that day, to everyone's surprise, when he looked at all this, what he said was, no issue. This is just a normal ECG. He waved off all the interpretation by the ECG machine and said that these are all normal morphological changes that are secondary to the elevated fitness level of this participant. So what this means is that he actually overruled all the interpretation by the ECG machine and said that, hey, this guy is extremely fit and that's why you're seeing all these anomalies in his ECG report. He's all fit, good to go. And that's perhaps the reason why today we need to learn all these learning outcomes. And the first is the cardiovascular adaptations following exercise training what are they, what's normal and what's not normal. And with that, hopefully, we would then be able to identify some of the ECG features of a well-trained athlete, so that in the future, if you happen to be sitting in that attending physician's seat, you would know that this guy is actually safe for endurance exercises or this guy is not. Okay, so that's here. We are here to help you to make the right judgment. Okay, so I'm going to get started with a quick recap of the cardiopulmonary system. And I always like to tell students that I see the cardiopulmonary system like a logistic or transport company. Because for all logistic company, you always need your ground cargo workers to be carrying supplies from the supplier and then circulate it to consumer. And that is exactly how your cardiopulmonary system works, because in our body, we have our red blood cells, just like your minions, your transport workers. They are the ones that carry your cargo from your supplier. In this case, cargo is like your oxygen, supplier is your lung. Alright, and oxygen is going to be circulated through your warehouse. In this case, is your heart, and then delivered to your consumers. And in our body, consumers would then be our exercising muscles or the various tissues in the body. So once the cargo has been delivered, red blood cells get returned to the warehouse, and then it recirculates again to the supplier, which is your lungs, and the cycles continue again and again. But like all businesses out there, you will always need to have a ground manager dictating how hard your workers work. And in this case, our ground manager would then be your SA node, because it's the one that dictates your heart rate and how fast your red blood cell has to be circulated. Of course, just like any other companies, on top of your manager, you have your board of director or your CEO, right? And that's the one that lays out the overall policy of the company and make sure how everybody works. And for us, your CEO would then be like your brain, because your brain is the ones that dictate how fast your SA node fires. Now, what's more important for everybody to learn here and to take note is that just like any logistic company, in fact, any businesses out there, the supply has to be always dictated by the demand, right? How much demand would dictate how much supply, and in this case, your muscles are the ones that are the ultimate consumers or the boss that tells how much demand it needs, and with that, the body has to adjust according to the demand and supply accordingly. So what this means is that the supply of oxygen or your cardiac output must always be there to match the demand from your consumers or your exercising muscles or any tissues. And this is exactly what we see when we measure cardiac output in response to exercise. Okay, so if we put somebody on the treadmill, let's say here, and we measure the cardiac output of this person with increasing exercise intensity. Okay, so exercise intensity increase, you naturally see an increasing cardiac output, because your cardiac output needs to meet the energy demand from the exercising muscles. But eventually, this cardiac output has to plateau. It can only go up to its max, right? And that is when this person reaches exhaustion. Okay, so when that plateaus happens, what you'll get is your maximum cardiac output. And let's say now we have a maximum cardiac output from somebody who is untrained before training. What you will see from somebody who has undergone training is something like this. Okay, you'll see that the cardiac output rises, but eventually it plateaus. It plateaus at a much later time, and it plateaus at a much higher level. In other words, this guy can last longer, improve endurance training. And what this also means is that the cardiac output has to match the increased endurance, and that will come with an elevated maximal cardiac output. So what this means is that the cardiovascular system has to change, and there needs to be adaptive response such that cardiac output can increase to support this improved endurance performance. So the question here is that what are the post-training cardiovascular changes that enables the improvement in cardiac output? And that is something that we will try to address today. So this is how we are going to study the changes in cardiovascular system following endurance exercise training. We are going to categorize it into 4 categories: the blood volume changes, as well as its composition, the changes in the cardiac structure itself, and with that, how does it impact the stroke volume as well as the heart rate of the heart following endurance training. We'll visit all this one by one. We're going to get started with your blood volume. So if you were to look at the blood before and after training, the first thing that you will notice from here is a general increase in blood volume. Okay, from here to here, there's a general increase in blood volume. And in fact, the general increase in blood volume is amongst the earliest training adaptations you would see. But what you will also notice is that the red blood cell volume also increase, and the plasma volume increases as well. But if you are sharp enough, you'll notice that the increase in plasma volume is much greater relative to the increase in your red blood cells volume. Because of that, the percentage of volume in which your red blood cells are occupied in the blood, in the total blood, actually drops because there's a dilution in a way, because there's greater plasma volume increase. So what this means is that with endurance training, despite the increase in red blood cells and despite the increase in blood volume, the hematocrit actually drops. Okay, the hematocrit level actually drops because the percentage in which your red blood cells volume occupied actually drops. And what this means is that somebody who has undergone exercise training tends to have a lower blood viscosity because of the lower hematocrit. Now, what kind of mechanisms are there that enables the changes in blood volume? The first mechanism involved is actually the increased synthesis of albumin from the liver. And albumin is a globular protein in the blood that helps to retain fluid in the circulation. So when there's more albumin, there's greater oncotic pressure, and that helps to retain the plasma, the fluid into the circulation, and hence plasma volume will increase. Now, if you want to learn more about oncotic pressure, you can click on this link. It will bring you to a YouTube video that explains a little bit more on oncotic pressure. Now, other than the increased synthesis of albumin, there's also an increased synthesis of erythropoietin in response to the hypoxia from the exercising muscles. So there's more stimulus for erythropoietin production, and with time, there's also increase in the synthesis of red blood cells. And that, of course, contributes to the increase in the RBC volume as well. So these are the mechanisms that contributes to the changes, adaptive changes following exercise training in the blood. Now, based on what you have learned here, if you try to apply your learning, my first question to you is, what do you think were the cardiovascular anomalies that is related to the blood volume changes following exercise training? So with the changes in blood volume and composition that you see following training, which are the anomalies that could have been contributed by it? Left ventricular hypertrophy, ST elevation, sinus bradycardia, low blood pressure, as well as the red blood cells in urine, which are related potentially to these changes in RBC and blood volume. Now, the answer from the question here is actually low resting blood pressure. Why? It's because of the drop in the hematocrit. If you recall from the previous slide, the drop in hematocrit will actually reduce the blood viscosity level, and your diastolic pressure is very much dictated by the blood viscosity or the peripheral resistance itself. So with the drop in blood viscosity, peripheral resistance drop, and diastolic pressure tends to drop. In fact, overall blood pressure tends to drop as well. So in very well-trained athletes, you tend to see a lower end of resting blood pressure in them. Okay, we are done with the changes in blood volume and composition following exercise training. We're going to move on to the structural changes in the heart with endurance training. So if you look at the heart structure of an endurance athlete and we compare it with that of somebody who is untrained, So if you look at this figure here, this is a typical heart structure of somebody who is untrained, sedentary, but it's a healthy heart that we are looking at. And if you were to compare it with an endurance athlete's heart, first thing that you'll notice is a clear left ventricle hypertrophy, right? The left ventricle here is much larger. And when I say much larger, what I mean is that there's increase in left ventricle diameter, the wall thickness, as well as the mass itself, right? Greater muscle mass. And in fact, this is the main reason for the increase in maximal cardiac output that we see in endurance athletes. The bigger left ventricle means that it can have greater volume contained. In other words, larger end diastolic volume. With that, there's greater stroke volume. And because stroke volume multiplied by heart rate equals to cardiac output, right? That means that there's greater maximal cardiac output as well. And you will need to see that this left ventricle hypertrophy here is secondary to cardiovascular fitness. It is not pathological. In fact, this increase in left ventricle size is an adaptive response to the increased fitness of the individual. And if you were to compare this endurance athlete's heart with one from suffering from hypertensive left ventricular hypertrophy, or those from hypertrophic cardiomyopathy, this is a congenital disease, it is very much different. So for example, if you were to compare the heart of an endurance athlete with a hypertensive heart, the first thing you will notice is that the left ventricle diastolic dimension, see the lumen here, is much smaller in that of a hypertensive heart. So with that, stroke volume is compromised as well. And the other, which you may not notice from here, is the fact that the distensibility of the hypertensive heart would be much poorer as compared to the endurance athlete heart as well. And this is because there's increased scarring in the cardiac tissues of the hypertensive heart because of the constant eccentric contraction. In other words, the heart has to contract against a greater afterload, and for that reason, there's more scarring of the cardiac tissues, and that affects the distensibility or the stretchability of the cardiac tissues. So yes, we have discussed about the difference in the heart structure in endurance athlete. Essentially, there's left ventricle hypertrophy. So if you were to apply what you have learned here, and start asking ourselves again, which do you think were the cardiac anomalies on the ECG report that you have seen that could potentially be related to the training-induced left ventricular hypertrophy in athlete? Was it the acute myocardial infarction, low resting BP, first degree AV block, sinus bradycardia, or was it RBC in urine that's related to LVH in athletes? Which would it be? Okay, now you have answered first degree heart block or sinus bradycardia. Congratulations. We are going to try and explain why here. Now if you look at the ECG report that I've shown to you guys previously, the first thing you'll see here is a very low resting heart rate here, and that is your sinus bradycardia. And this can be explained by the left ventricle hypertrophy that we are seeing because of the huge ventricle. What this means is that there's very large increase in stroke volume, and stroke volume multiplied by heart rate equals to cardiac output, right? So for us to maintain the same cardiac output when stroke volume is very high, your heart need not pump as fast to supply the same cardiac output. So what this means is that with one big stroke, you can pump out a lot of blood, so you don't have to pump a lot of times. Because of that, resting heart rate is very low as compared to sedentary untrained individuals, and that sinus bradycardia that you see is secondary to the fitness itself, secondary to LVH itself. Now, of course, for us to be able to achieve a low heart rate, what this means is that there's also need to be an increase in vagal tone, your parasympathetic stimulation. And for that reason, the cardiac cycle would be very much lengthened because of the increased vagal tone as well. So the firing from the SA node has to be slowed down significantly. Now, because of that slowing down in your SA node firing and the increase in vagal tone, what you tend to see is also signs of first degree AV block, because when we look at first degree AV block, what we are looking at is the communication between the SA node and the AV node. So that is actually depicted by your PR interval here, right? Your PR interval, which is here, right, is an indication of your conduction between your SA node and your AV node. So with increased vagal tone, the entire cardiac cycle is lengthened. So is the case of your PR interval. And when your PR interval is lengthened so much that it's more than 0.2 milliseconds, that is usually interpreted as a first degree AV block. Right? There's issue with the conduction between your AV node and your SA node. But of course, in this case, it is not because of an issue in the conduction. It's more because of the increase in vagal tone that is secondary to the physical fitness itself. Okay, now we are done with the structural changes in the heart following exercise training. We will move our attention over to the stroke volume and heart rate changes in response to the structural changes that you have seen. So if we again put somebody on the treadmill and we measure the stroke volume changes following exercise during exercise itself, if you start somebody on the treadmill exercise and push that person all the way until exhaustion, what you'll see is an increase in stroke volume. But at about 50% of the exercise intensity, you will start to plateau. This increase in stroke volume is because of the increased muscular and respiratory pump during exercise. So it compress on your veins and push more blood back to the heart. So there's increased venous return and hence there's increased stroke volume. But this increase will only go all the way until about 50%, and after that it will plateau. In somebody who is well trained, this increase in stroke volume would differ. In the first place, somebody who is well trained would have an elevated stroke volume even at rest, and at any given exercise intensity, stroke volume will be higher because of left ventricular hypertrophy. In fact, the plateau will come much later on at a higher exercise intensity as well. So yes, stroke volume, maximal stroke volume will be increased. Resting stroke volume will be increased as well following endurance training. Now we learned that cardiac output equals to stroke volume multiplied by heart rate, right? So if somebody's stroke volume increase, and if you want to supply the same amount of cardiac output, your heart do not need to pump as hard. So naturally, you expect a lower heart rate. Is that what we see? So if you were to look at the heart rate increase with exercise intensity, you can see that it does increase as expected, and then it plateaus, and this is for an untrained individual. For a trained individual, what you see is a general reduction in your heart rate for resting heart rate as well as any given exercise intensity. Okay, the heart rate will be lower. Why? Because it can supply the same amount of blood without the need to pump so fast due to the increase in stroke volume. Now what I want to highlight to everybody here is this. Now with training, somebody will be able to achieve maximal heart rate at a much later exercise intensity. So endurance is increased, exhaustion comes later, right? But what you will notice is that the maximal heart rate here is very much comparable. It doesn't, somebody who is trained doesn't have much higher maximal heart rate. Your maximal heart rate doesn't increase. In fact, it is similar between the untrained and the trained. Why? It's because when there's increase in heart rate, right, what this means is that there's less time for ventricular filling as well. And that is especially pertinent for well-trained endurance athlete because the left ventricle is very large. You need more time for ventricular filling, right? So if the heart pumps too fast, it will be pumping out the blood even before the left ventricle is fully filled. So that's inefficient. Okay, so what this means is that in very well-trained athletes, you will not see an increase in maximal heart rate. If anything, maximal heart rate might even drop because you will need more time for ventricular filling in very well-trained athletes with huge left ventricle. And that, in fact, helps to explain the final anomaly that you see in this ECG, which is your ST elevation, which is a sign of acute myocardial infarction. Okay, so that ST elevation, V2, V3, ST elevation is here that we are seeing. And this is actually secondary to, again, cardiovascular fitness as well. This is something that what we call an early repolarization pattern. Why? It's because, as what I've explained to you, when there's huge left ventricle, you need more time for ventricular filling. So in order for the heart to achieve or maximize the time for ventricular filling, it needs to repolarize earlier. Right? What this means is that the T wave is shifted leftwards so that it can repolarize fast earlier, and that allows for greater time of relaxation and filling of the left ventricle. So because of that, when T wave is shifted earlier, closer towards the QRS axis, it appears as if the ST segment is elevated just because the T wave is shifted earlier. And that gives this early repolarization pattern is often misinterpreted by the machine as ST elevation, which is false positive. Okay, so that explains why the attending physician was very comfortable to strike this off and say that, hey, this guy is fit and he's safe, his heart is healthy. All right. Now, some of you may also notice that, hey, in this medical report, there is also red blood cells present in the urine and ALT, AST is elevated. So isn't this a concern? So what happened was that, through, that's why clinical history taking is important, because the attending physician, after speaking to this guy, he found out that it is not the best, most compliant participant you can have, because the participant actually went for the medical screening the day immediately after his full marathon. So what happened was that during a full marathon, one can be very much dehydrated because of the prolonged running. And when that happens, the bladder, right, during the run itself, the bladder wall may actually have shuffling, and that may cause some mild bleeding from the bladder wall into the urine. And that explains why there's RBC present in the urine. Now, of course, with marathon, when one finish it with in a pretty good time, what this means is that the intensity is very high, so there can be muscle damage as well, and that may result in the release of AST, ALT into the muscles, and with that is again another false positive. So yes, the guy wasn't the most compliant. And then again, if you are worried that, hey, how come you can have consent to share all this with us, you don't have to worry as well, because consent has been given, because this not so compliant person happened to be the one giving you the lecture for this particular session, and that was me about more than a decade back. Okay, which also explains why I'm in a good position to deliver this lecture to you. But all in all, it is important for you to learn that there are physiological changes in response to exercise training when somebody gets fit, and we need to know how to differentiate what's normal and what's pathological. And hopefully this particular lecture helps to raise some awareness in all of you. Okay, with that, this is my summary slide on the cardiovascular changes of somebody who has gone through endurance training as compared to pre-training, as well as that values from somebody who is a world-class endurance athlete. This is just a quick recap for you to look at it on your own free time and see whether you can validate your learning from here. I'm not going to go through this. Okay? With that, I'm going to leave you with one final word of wisdom from me, because this is probably the last time you'll be hearing from me for your phase 1, maybe even your entire medical study. But yes, We have always been chasing after a panacea in our medical world. A lot of research and time and money has been put into finding the best drug. My word of wisdom for everybody is that actually we already have one. The closest medicine that we have towards a panacea is actually consistent exercise. Okay? And of course, that consistent exercise has to be done at the right dose. You cannot overdo it. Do it at the right consistency and right dose, and that's the best panacea that we have towards curing all illnesses. In fact, if you are interested in this, there's a program called Exercise is Medicine that you can explore in the future after you get your MBBS. Because today we actually have a program to teach physicians how to prescribe exercise to manage all sorts of chronic diseases. And there are actually structured exercise that we can prescribe for them based on the condition that they are facing. And yes, that sums up the entire session today. And just remember, exercise is a real medicine. Thank you.